My name is Michael Surzan. I'm a medical oncology fellow at the Georgetown Lombardi Comprehensive Cancer Center, and I'm delighted to share highlights from our paper entitled Current and Emerging Therapies for the First-Line Treatment of Metastatic Clear Cell Renal Cell Carcinoma. Over the past 15 years, advances in the understanding of the biology of RCC have led to the discovery of agents that target the angiogenesis and immune pathways. These therapies have dramatically improved outcomes for patients with metastatic disease. In this video abstract, we discuss the historical, current, and emerging therapies for first-line treatment of RCC. The first breakthrough came with agents targeting the angiogenesis with vascular endothelial growth factor, or VEGF TKIs. Trials of sunitinib and pazopanib in the frontline setting demonstrated improved response rates and PFS when compared with interferon or placebo, respectively. Cabozantinib and lenvatinib are multi-kinase inhibitors that target VEGF as well as other pathways to prevent angiogenic escape. These agents have both improved responses and PFS relative to sunitinib in the front line, however have not shown an OS benefit. The IMDC and MSKCC groups sought to utilize clinical and lab criteria to predict responses to VEGF therapy and interferon, respectively. Patients with no factors had favorable risk, 1 to 2 factors intermediate risk, and greater than 3 factors poor risk disease. In the frontline CoMPARS non-inferiority trial of sunitinib and pazopanib, patients with favorable risk disease had a median OS of 42 months compared to just 26 months with intermediate risk and 8 months with poor risk disease. In summary, VEGF TKI therapy represents a historical standard of care with improvements in only response rates and PFS. However, the durability of response is limited, particularly in patients with intermediate and poor risk disease. The current role of frontline VEGF TKI monotherapy is likely only for patients with an aversion to immune checkpoint inhibitors. The second major breakthrough in advanced RCC came with the use of immune checkpoint inhibitors. Nivolumab and ipilimumab are monoclonal antibodies that block key immune checkpoints, namely PD-1 and CTLA, leading to restitution of the endogenous immune response. CheckMate 214 is a randomized phase 3 trial of frontline nivo-ipi compared to sunitinib. The study met 2 of its 3 primary endpoints, with nivo-ipi demonstrating an improvement in overall survival in the intermediate poor-risk population with a hazard ratio of 0.66. An OS benefit was also observed in the ITT population with a hazard ratio of 0.72. However, there was no difference in OS in patients with favorable risk disease. The study did not show an improvement in median PFS in the intermediate, poor, or ITT populations. However, in these populations, a plateau in the PFS curves was seen at about 35%, suggesting a small subset of patients who had responses remained progression-free at 42 months. In the favorable risk population, PFS initially favored sunitinib. However, that early benefit appears to have diminished over time with convergence of the PFS curves at 42 months. When broken down by IMDC risk groups, patients with favorable risk disease who were treated with nivo-ipi were shown to have similar response rates and PFS when compared with intermediate and poor risk disease. These observations suggest that nivo-ipi is an active regimen regardless of IMDC risk categorization. A population of particular interest in the study was 145 patients with sarcomatoid RCC, a histology associated with aggressive disease. Patients treated with nivo-ipi were demonstrated to have significant improvements in response rate, PFS, and OS relative to sunitinib. This data suggests that nivo-ipi is a standard of care for patients with sarcomatoid histology. As data from CheckMate 214 continue to mature, a novel endpoint has emerged to quantify time that patients remained on trial without active treatment. Treatment-free survival is defined as the period of time between when patients stop IO or VEGF therapy due to toxicity or completion and initiate a subsequent therapy or death. In patients with favorable risk disease, treatment-free survival on nivo-ipi was 11 months, nearly 3 times as long as the 3.7 months on sunitinib. Similarly, in patients with intermediate and poor risk disease, treatment-free survival on nivo-ipi was 6.9 months, nearly double the 3.1 months on sunitinib. In summary, frontline nivo-ipi represents a standard of care for patients with intermediate and poor risk disease, as well as those with sarcomatoid histology. The goal and benefit of IO doublet therapy is durable disease response with plateaus in the PFS and OS curves, as well as prolonged treatment-free survival. There is toxicity due to immune-related adverse events, often occurring early and usually reversible with immunosuppressive therapies. For patients with favorable risk disease, there is activity of nivo-ipi, as well as single-agent anti-PD-1 therapy, which has been demonstrated in smaller phase 2 trials that warrants further evaluation. With the success of approaches targeting angiogenesis and immune checkpoints, a series of large phase 3 trials were launched using VEGF TKI as well as anti-PD-1 or PD-L1 therapies for patients with all-risk disease. These trials all used sunitinib as the control and had slightly different primary endpoints aimed at improving PFS. Nearly all of these trials demonstrated improvements in response rates, PFS, and OS relative to sunitinib alone. Acknowledging the limits of cross-trial comparisons, cabo-nivo and lenvatinib pembro were observed to have numerically better hazard ratios for PFS and OS relative to axitinib and pembro or axitinib and nivolumab. Interestingly, interim follow-up on the axitinib pembro and axitinib everolimus trials has shown an increase in hazard ratio from 0.53 to 0.68 and 0.69 to 0.80 respectively, perhaps suggesting a loss of OS benefit over time. As data on these trials continue to mature, particular attention will be given to the ability for these regimens to form a plateau on the PFS and OS curves. In summary, frontline VEGF IO therapy has demonstrated improvements in early outcomes of response rates and PFS across IMDC risk groups. It represents a standard of care for patients with symptomatic disease requiring rapid disease control or those with a contraindication to ipilimumab. However, the durability of response is uncertain, toxicity is cumulative, and it remains unclear if this regimen can produce treatment-free intervals. There are several ongoing trials investigating frontline doublet and triplet VEGF IO combination therapies. Additionally, trials are underway evaluating the use of systemic therapy combinations with surgery or radiation. In conclusion, first-line therapy for clear cell renal cell carcinoma is a rapidly evolving field with multiple treatment regimens that have showed improved outcomes. The choice of first-line regimen currently depends on individual patient histology, clinical characteristics, and the goals of therapy. Some areas for future development are the validation of biomarkers such as gene expression profiles to match disease biology with rational targeted drug combinations, as well as the incorporation of novel agents which target the angiogenesis and immune pathways. We thank you for your attention and hope you enjoy our paper.